Now then, okay. So the idea is to just drop in and pick a few topics and think about them, give you some little sort of on-screen tests. I'm not going to single out anybody. We're not going to have clickers or people raising their hands or anything like that. This is kind of like personal reflection, or if you want to talk to the person next to you to help you along the way, then that's fine. So basically we're dealing with the musculoskeletal system. When Carl does his presentation on Monday, there may be some similarity with some of the content. That's simply because I don't know what he's going to present, nor did he know what I'm going to present. So a lot of what I've been talking about, the thorax and abdomen, the appendicular skeleton, the pelvic and pectoral girdles, are skeletal elements with the associated ligaments and muscles, of which you'll come to, or have come to know and love. I'm poaching a little bit into Carl's area here, looking at the vertebral column, the axial skeleton, and just as a starting point, you should be able to identify where along the vertebral column different vertebrae occur, not necessarily to this precise position like L2 or L3, but at least the cervical, thoracic and lumbar vertebrae. And you should, if questioned about them, be able to basically provide a description. And I'll come to some of the questions we sort of might ask later. And this is just to remind us that there are obvious similarities in the vertebrae, but also clear differences. And so if you think about the cervical vertebrae for a moment, think about what you would decide as being the real characteristics of that region of the body. And I'm thinking about the typical vertebrae. We'll worry about the more specialized ones in a moment. So what characteristics would really distinguish a cervical vertebra from a thoracic or a lumbar vertebra? And I suppose, in reality, thinking about what a lumbar vertebra is a good starting point, because these are pretty much the basic form of which we see modifications in other regions of the spine. Anyway, the cervical vertebra, you might come up with the comments that it has a relatively small vertebral body or centrum, simply because you're really only supporting the weight of the head at this region of the vertebral column. So you don't need a large, robust vertebral centrum to support that load. The other obvious feature is that the vertebral foramen up here is very large. And the reason for that is because the spinal cord passes through the vertebral foramen, and at this point in the neck, it's basically at its largest. It's conducting all the information from the body to the brain and from the brain to the body, all passing through this region. And so there's a lot of neural material has to be accommodated, and hence the space is large. There are also these transverse foramen, one on each side of the vertebra, for passage of the vertebral arteries. And Phil, you might remember Phil Hughes as a cricketer who died, unfortunately, under tragic circumstances not so long ago. And it's likely that the vertebral artery on one side of the neck may have been lacerated and the cricket ball hit at high speed into that lateral neck region. And it may well have been, I don't know, it hasn't been released, but it could have been that a fracturing here ruptured a vertebral artery with devastating consequences, because this artery runs up to feed blood to the brain. Bifid spinous processes is the other obvious feature. So ligamentum nuchae will sit in this, which is the ligamentum nuchae is the extension of the supraspinous ligament that you find further inferiorly along the vertebral column. There are other features, but these are probably the major ones that you might think about. In the thoracic vertebra, the body is now kind of intermediate in size between the cervical and the lumbar vertebra. And the foramen is smaller than the cervical vertebra because now a lot of the peripheral nerves that have gone off to service the upper limbs are absent from the spinal cord. So hence there's not as much neural tissue in this region. The articular facets on the body and transverse processes are present there for articulation with the ribs, and more of that in a moment. So on all of the vertebrae, you will find one or other or both of these features, these articular facets, and the transverse costal facets, excuse me. And these have long and downward pointing spinous processes. So in the cervical region, the spinous processes get progressively longer as we go from, basically from I'll say C1, but from the proximal to the more distal, as in C1 through to C7, with C7 being the vertebra prominens, the long one that you can palpate at the back of your neck, base of your neck. Lumbar vertebrae, I say the more sort of standard vertebra, large vertebral body, small-ish triangular vertebral foramen, and thick, blunt spinous processes. And there are all the other features, which I'll come to in a moment, that you could identify on this vertebra. Again, the smaller vertebral foramen is really because, again, most of the nerves, peripheral nerves, have gone from the spinal cord to service parts of the body superior to this region, and we've not really got too much left in terms of neural connections for the rest of the lower part of the body. So, thinking about the vertebral column, you might find in the short answer questions that are worth, I think, 5 marks, and you have about 7.5 minutes is recommended time to answer them, you might find, well, what I try and do is break a question up into subsections. There may be a single question, or there may be 2, or there may be 3 sub-questions, such that you don't put all of your eggs in one basket in answering a single topic area. This could be one of those sort of subsections. Describe the structure and function of the odontoid process, or DENS. This is the sort of answer I've had before. Grammatically incorrect. I'm an apostrophe Nazi. And anatomically incorrect. And that often accompanies such a thing. I can tell you now that smiley faces don't work for me. You still get nothing. What you might think of an answer would be something more like a bony peg-like structure of the axis, C2, located on the anterior aspect of the vertebra, projects superiorly, articulates via a synovial joint with the anterior arch of the atlas, C1, held in place by a transverse ligament of the atlas, acts as a pivot about which the atlas can rotate, as in the action of shaking one's head, indicating no. Now, there could be, obviously, subtle variations on the theme, but that would have pretty much the basis that I'm interested in covered. Always reflect back, of course, and look at the question to make sure you've answered the question being posed. It's describing the structure, so a lot of the comments are describing the structure and then the function. If you only describe its structure, then you will automatically only be able to get roughly half marks. So reflect back and try and make your answers kind of as complete as possible. Obviously don't make stuff up, because that doesn't work either. So just to remind ourselves about the structure, we're thinking about the upper cervical vertebra, C1 and C2, the atlas and the axis respectively, And here we see the atlas with its articular surfaces for the occipital condyles. So that will be the articulation, the synovial joint for the nodding of the head, whereas we're considering, and this is a posterior view, so we see the bifid spinous process of C2, and we can see the dens or odontoid process just poking up in this sort of slightly disarticulated image. And if we look on a schematic, that just reminds us of what the thing really looks like in terms of how it's held in place by that transverse ligament. And the movement of turning your head from side to side is not just due to that, of course, and the thing that I hadn't mentioned above is that the atlas and axis have their synovial articulations, these facets, which allow for that sliding movement, that rotation about the dens of the axis. So, it's all dead easy when you know the answer. It's a matter of getting there. So this was meant to be slightly animated, but everything's come up at once, so it gives you the answer. But explain why T1, T9, T10, 11, and 12 are considered atypical thoracic vertebrae. This one's a bit more tricky because you obviously have to know a fair bit more of the detail in terms of which ones are normal and which ones are abnormal and what the normal ones comprise. So maybe a way of answering this would be to define what a typical thoracic vertebra comprises. And it has these, remember when you're looking at a picture, you're often just looking at one side of it. So you have to remember that the costal demifacets, there's two, one for the rib on the left, one for the rib on the right side of the body. So it has two costal demifacets. So normally the head of the rib will articulate, it effectively comes in where the intervertebral disc is and has a bit of an articulation with the superior and the inferior vertebral body at these demifacets. And then for most of the normal vertebrae, we have transverse processes, and they have a little costal facet on those. So that transverse costal facet is the one which articulates with the tubercle of the rib. So remember, ribs have, as we'll see in a moment, a head with an articular surface. It's actually two, but we'll see that again in a second. And also an articulation at the tubercle, just near the angle of the rib. So that would define a typical one, which you can then more easily go forward and describe where the others differ from that model. And this is self-explanatory. So T1 has a complete superior costal, or has complete superior costal facets, one on either side, left and right, rather than the superior costal demifacet. That's because rib 1 is just articulating solely with that complete facet. T9, it lacks inferior costal demifacets. We'll see the images in a moment. T10 to T12 lack the inferior costal demifacet, and they have complete superior costal facets. And T11 and 12 do not have those transverse costal facets. There is no articulation with the rib at that point because there's no tubercle on ribs 11 and 12. So just to remind us of this region of the body, here we have our thoracic cage viewed posteriorly and anteriorly. With the true ribs, ribs 1 to 7, remember, they're connecting directly with their own costal cartilages to parts of the sternum. But then when we get down to rib 8, we get to the point where it starts connecting via its neighbor. Basically, its costal cartilage is merging with that of rib 7, so it doesn't have its own unique attachment to the sternum. And that occurs for ribs 8, 9, and 10. And of course, ribs 11 and 12 are the floating ribs that don't have this connection to the sternum. So on the right-hand side, we see the atypical vertebrae. This is lifted from your lecture on the subject. On the left-hand side, we have a thoracic vertebra. We can see it's a thoracic vertebra because it's got these costal facets. And just think for a moment, what are the names you would apply for A, B, C, D, E, F, and G? And you would find all of these on the typical vertebrae, thoracic vertebrae. So you might have the names, or you might not have all of the names. So the names are here, but not in necessarily the right order. And it's much easier, of course, as you know from being in the lab and doing this sort of thing, it's much easier once you have the names to link them to the object. Coming up with the names de novo is a little bit more tricky, but it's a good thing if you can do it. And so putting letters to names, we actually see they're that. I hope they're that, because I just have to check myself. So what we haven't really mentioned up until this point is the articular facets. Remember, the vertebrae have a pair of superior articular facets that articulate with the pair of inferior articular facets from the vertebra above. And those, again, are small, basically flat, plane joints, synovial joints. And it's the combination of all of these joints up and down the vertebral column that allows for the variation in movement that we have in flexion, extension, lateral rotation, or lateral flexion, sorry, and rotations about the longitudinal axis of the vertebral column. And different regions of the spine have different degrees of freedom in movement. And that's really based on the fact that these facets point in different directions as you look from the cervical region right down to the lumbar region. And it permits different sorts of movement at different joints. So, going back to our question about why they are atypical, here we have that single superior costal facet. It's a complete thing, whereas the inferior one is a demifacet. It's only half of one. And thoracic vertebra 2 would be sitting here, and it would have the other half of the demifacet. And the head of the rib would articulate both with vertebra 1 and 2 in the thoracic region. That would be rib 2. A single superior costal demifacet on vertebra T9. It lacks this inferior articulation. And that's because when we get to T10, we have a whole costal facet present. So rib 10 only articulates with T10, as does rib 11 with T11, rib 12 with T12. And finally, the lack of a transverse costal facet for the floating ribs. And just to show things in an articulated form, here we can see a rib. It could be rib 6. It would be articulating with the thoracic vertebra 5 and thoracic vertebra 6. And, of course, we have the two demifacets on the vertebral bodies. We have two little facets, actually, on the head of the rib. So it's not a single articular surface. There's two there. And then we can see the tubercle of the rib, and that will be articulating with the thoracic vertebra of the same number. So rib 6 articulates with T6. And the exceptions of the ribs are shown below, and you can map that back against the previous slides. Is a different way of thinking about this. Same information, just a different presentation. And again, just to remind us, ribs vary in shape and size, as the thoracic cavity is not just a cylinder, and these are articulated both anteriorly and posteriorly, which means that we have this ability to move the thoracic cage for inspiration and expiration. Oh yes, see, I've underlined the S for facets because there are in fact those two facets on most of the heads of the ribs for the articulation with the two demifacets from adjacent vertebrae. And that just gives you another view of the same thing. So, sticking with the thorax, name those features. They're not all named, as in they're not all pointed at, but have a look at what these are, make a guess or an estimate of what they are. That's rib 1, 2, 3, 4, 5, 6, 7. That'd be rib 7. So hopefully you've come up with the names. And if you're being clever, you could actually say which costal cartilages they are, because you can count down from rib 1 and give them a number if you felt like. And of course, the movement of the rib cage reflects back to an earlier lecture where we were thinking about both the pump handle mechanism and the bucket handle mechanism in terms of, as the ribs rotate, basically rotating by their articulations with the vertebral column, they're rotating both upward, and also it causes an expansion of the diameter, both in the lateral and the anterior-posterior direction, such that you increase the volume of the chest, and in so doing create a bit of a negative pressure as the lungs are expanding as well, because they're attached via the pleurae, attached to the internal walls of the chest. Chest expands, lungs expand, air pressure in the lungs drops, so you open your mouth and air is drawn in to the lungs, hence inspiration. Who can remember which muscles are involved in inspiration? There's a few, and a couple of them are probably less obvious than others. So let's have a look. On the anterior side of the body, we have the scalenes. They're actually broken into anterior, middle, and posterior, but I'm happy if you just know them as the scalenes. And basically, they're originating from C1 in the case of the middle version, but C3 through C6 for the ones that run to the rib 1, and the posterior scalenes, C4 to C6, that run to rib 2. But basically, as we said in the lecture, the scalenes run from the cervical region attached to the upper two ribs. Shortening of those, if you keep your neck in a fixed position, will elevate the upper two ribs, and the other ribs will follow in unison. The external intercostals are the ones that are involved in inspiration, active inspiration. If you think about the external intercostals, if you remember, you put your hands on your side of your thorax, the direction of the fingers effectively indicates the direction of those fibers. And if you move your hand back, oh, I can't move it right round to my posterior surface. But what it would mean is that the fibers that originate, let's say they originate on the vertebrae or adjacent to the upper rib of the two that we're considering, it will attach more or less at the junction where the vertebra and the rib meet, and then it runs inferiorly and laterally. So a shortening of those fibers because you can think of the upper portion being fixed. It's effectively fixed to the vertebra. A shortening of those fibers will pull the lower rib upwards. So that's why the externals are the elevators of the rib cage. We also have, although I didn't talk about it, but I presume Carl did, serratus posterior. Comes in two groups, the superior and the inferior group. And the superior group runs from the spinous processes of C7 and the upper thoracic vertebrae and runs to ribs 2 to 5. Again, it has its origin near the vertebral column or on the vertebral column and runs inferiorly and laterally. So a shortening, again, elevates the ribs. So they're kind of considered the main elevators. But I did mention, I think in passing, that pectoralis major and pectoralis minor, with their relevant attachments shown there, can also do it. But normally, because they're running from the ribs up to attach predominantly onto the scapula, there are other sites of origin for pectoralis major. Normally what would happen is that the contraction of that muscle has an effect on the shoulder joint rather than elevating the ribs. But there are certain circumstances, for example, when you've just done a 200-meter sprint and you're out of puff, people quite often brace themselves, they lean over, they brace their hands on their knees or just above the knee, and in so doing they fix the position of the scapula. And then pectoralis minor and pectoralis major are in a position operating from a fixed scapula to help elevate the ribs. So it's kind of like a bit of an unusual function that your textbook, I don't think, actually tells you. As such, I wouldn't expect you necessarily to put that in any given answer. All of the things that we've been talking about, the skeleton and the muscles, really involve the joints as allowing for movement between adjacent or interconnected parts of the skeleton. Cartilaginous joints, I'm just sort of dropping in, as I said, different things. Cartilaginous joints, well, of course, during growth, we have hyaline cartilage forming growth plates, the epiphyseal plates, which allow for lengthening of many of the bones of our body. And they will form a synchondrosis. Basically, it's a kind of like an immovable cartilaginous joint. Other cartilaginous joints are shown here in the sagittal section. Through the vertebral column, we can see the intervertebral discs, and these are fibrocartilaginous pads. And in the same way, at the pubic symphysis, joining the two pubic bones, acts as a fibrocartilaginous pad and forms a symphysis. Synovial joints have a whole variety of potential inclusions apart from their normal structure, and we've met various ligaments. Remember, ligaments go from bone to bone. They're a dense, fairly regular connective tissue, and they're very good at resisting tension. And ligaments can be extracapsular, capsular, or intracapsular in form. So extracapsular are the things like the medial collateral ligament at the knee, or the lateral or fibular collateral ligament. They sit outside of the capsule. Some of them are actually blended in to the capsular wall, and others, such as the anterior and posterior cruciate ligaments of the knee, are actually found inside. They're intracapsular ligaments. Other things are just there for reference. Again, going into Carl's area, the temporomandibular joint is a funny joint in as much that it is a synovial joint, but it has this interarticular inclusion of a basically a pad, which gives the joint extra freedom of movement. So normally we associate 3 degrees of rotational movement with a ball and socket joint, such as the hip or the shoulder. But the temporomandibular joint has these 3 degrees of rotational freedom. They're not always very great, but they are there. And in some ways, this inclusion of a pad in between the articular surfaces proper is acting as a spacer. And you can depress your jaw, you can lower your jaw a little bit, and you can then raise it again. You can offset it to the side very slightly. And these things are translational movements, and you can move in the X, Y, and Z planes. And it's important for the processing, the physical processing of chewing, cutting and grinding. And we're not the best examples of this. If you ever get bored, go and watch a cow chewing the cud, because their temporomandibular joint is much more mobile than ours. Ours is mostly for opening and closing, elevation and depression. But cows can move the lower jaw markedly from side to side in a translation. They can skew it. They can rotate it. They have 6 good degrees of freedom, which makes chewing for them probably a delight. Bursa. We've met bursa briefly. These are basically enclosed sacs containing synovial fluid and act as a spacer again so that muscles or tendons don't pass directly over a bone surface where they might have a lot of friction associated with movement, and it would damage those structures. So we have a lot of bursae around the shoulder joint and around the knee joint and other joints in the body. In the hand, we have synovial sheaths to allow the tendons that flex the digits and extend the digits to move with little friction. And again, it preserves their integrity. So you see the tendon basically running through a tube, a cylinder. It's like having a balloon and then pushing your finger into the balloon. It creates a double wall of the sheath, and that contains the synovial fluid. And synovial fluid in joints is very important because it reduces the friction such that articular cartilage with synovial fluid has a coefficient of friction which is incredibly low, which means it's very slippery. Much more slippery than even having an ice cube rubbing on another smooth ice cube. That's how slippery your joints are. And just a little bit of quick physics. If you look at friction against the external applied force, you often find that some things they're hard to start moving. You push on them, you're applying more and more force, the frictional force is stopping the thing moving, rise and rise and rise to a certain point where it suddenly starts moving, and the frictional force drops and then remains constant. And it's really because when things are sitting still, there's a little bit of the surface irregularities kind of lock them together. Once you start them moving, then those things are actually, because the surfaces are moving relative to each other, they're effectively sort of bouncing along and don't lock any longer. So hence you get this little drop in the friction. But what we do with our joints, this would probably be what would happen if we had dry joints, or if you had osteoarthritis, it would be something similar to this. But we have lubrication in between the joint surfaces that keep the surfaces apart, and that means that the friction at the joint is very small. So lubrication is the answer. Depends what the question is as well, I suppose. My question to you here is, name those 5 question marks, bony landmarks. I've told you one of them, you always get a question about it, so I hope that will prove true in the end of the semester exam. So supraglenoid tubercle is possibly the one that was most tricky in terms of the only reason you would know it's there is because of biceps brachii. long head of biceps brachii originates from that supraglenoid tubercle, whereas the short head of biceps originates from where? Here, from the coracoid process. Remember, muscles, if you can't remember what they do, by thinking about where they attach, you can often work out what they do. So trapezius can elevate using the upper portion of the muscle. It can retract the shoulder joint by activating more medial portions or middle portions of trapezius. And it can depress by pulling down that medial border, medial aspect of the spine of the scapula. And it can rotate by activating those same fibers and also upper trapezius, basically pulling the lateral part of the shoulder upwards and medially while pulling the lower portion downwards and slightly medially. Or we can fix everything here and use the muscle to extend at the neck. Deltoid, as we mentioned, falls into three categories. We have the anterior, the middle, and the posterior fibers, condensing down to the deltoid tuberosity, and as such, abduction at the shoulder is a movement particularly of those middle fibers. Flexion and medial rotation is the action of the anterior fibers, and extension of the shoulder and lateral rotation of the humerus by those posterior fibers. One muscle, three subdivisions, and three pairs of movements associated with them. So, it is actually a little bit more complicated than I've even intimated, and that is because the anterior groups, you can split them further into effectively three regions, a single middle region, and three posterior regions. And then some people have gone even better and think they can get up to about a 9 or maybe even 11 subsects. But it tells you the principle there. We have subdivisions of a single muscle for these different functions. But how do we generate these different, so that's the shape of the muscle, how do we generate these different movements? Well, here's a schematic looking at your shoulder joint. We have the head of humerus sitting in the glenoid fossa with the little labrum, the lip, the fibrocartilaginous lip to make the fossa a little deeper, and the overlying acromion being the roof of the structure. That's the center of the joint rotation if we're thinking about abduction, adduction in this particular instance. So if you have a muscle originating there, a bit like deltoid middle fibers might do, what happens when you shorten the muscle fibers? You draw the two origin and insertion sites towards each other, and the joint rotates around its center of rotation. So you get abduction. If you had, let's say, the anterior fibers of deltoid, so this is, again, same center of rotation, but we're now, instead of having those lateral or middle fibers, we have the anterior fibers. If we restrict ourselves to what's happening in the plane of abduction and adduction, what happens when you contract this muscle? And the answer is nothing, because it passes over the insertion to origin line of action passes over that center of rotation. So this would neither abduct nor adduct the joint. However, if you think in 3 dimensions, this being a ball and socket joint, then a shortening of this muscle on the anterior aspect of the body would tend to rotate the joint towards you so that the humerus, distal humerus, moves out of the plane of the screen. So it would generate flexion. You need to, if you had the anterior fibers but a little more lateral, and they pass just with a small moment arm away from that center of rotation, then in a two-dimensional model, they would produce some degree of abduction, but it wouldn't be very strong. Because the strength of the movement depends on the force that the muscle creates, multiplied by the perpendicular distance from the line of action of the force to the center of rotation, which is really small. In here, it's non-existent. So the right-hand model would produce a little bit of abduction, but not much. Both these models would produce flexion. What happens when the acromion gets in the way? Let's say you can really shorten your muscles and you might get bone-on-bone impingement. And this is kind of what happens. You get to about 90 degrees, and then, or a little bit above. To go further, you have to rotate the whole of the scapula. So you start rotating everything as a unit, which allows you to elevate the upper limb further. But there's another way of doing it, and that is to externally rotate at the shoulder joint, and then you can lift the limb right up because of the kind of the shape, let's call it an L shape of the joint here. If you rotate it through 180 degrees, this part of the bone is replaced by effectively a bit more space, which gives you the ability to lift the limb much higher. That old favorite. Pectoralis minor, coracobrachialis, biceps brachii. What are their functions, though? Well, we've touched on pectoralis minor being a potential elevator of the ribs, but it depresses, protracts the shoulder, and downwardly rotates the scapula. Coracobrachialis is more straightforward. It adducts and flexes the shoulder. Biceps brachii flexes at the shoulder, not particularly well, and more importantly, I suppose, flexes at the elbow and supinates the forearm. So if you have a 90-degree flexion at the elbow joint, and you have a pronated hand position, forearm position, as you go into supination and you feel your biceps, you can feel it bulging up as it contracts. Interestingly, when you have a flexed elbow joint, but you're using your pronators to keep your forearm pronated, and you then flex the elbow, you can feel biceps, but biceps isn't involved. It still remains flabby. And that's because it's inhibited. It's wanting to supinate the forearm, but you're forcing your forearm into pronation. So that flexion is occurring via which muscle? That will be brachialis, because brachialis is just crossing from the humerus to the forearm and is not involved in supination or pronation. Just to remind us, elevation, depression, abduction and adduction of the scapula are equivalent to protraction and retraction effectively. Protraction is where you're abducting, but the scapula is always also moving around the curved thoracic wall. And then we have upward and downward rotation, and those movements are generated by, all of those movements are generated by a suite of muscles working together. That pronation and supination issue, biceps brachii attaching to the radial tuberosity, generally a powerful flexor of the forearm, but in the pronated position, it's inhibited. But if you don't force your forearm into pronation, you just relax it, then flexion and supination can be jointly produced by contraction of biceps brachii. And of course, the muscles really involved are supinator, biceps brachii for supination, and for pronation, pronator teres and pronator quadratus. Pronator teres originating from the medial epicondyle of the humerus. Remember, the line of action is where your thumb points, and it wraps around the radius. Supinator originates from the lateral epicondyle of the humerus and associated nearby regions, and attaches to the radius. So try and link in your minds where the muscles attach and what movements they generate. Sacroiliac joint. Important joint, the point of articulation between the axial skeleton and the appendicular skeleton in the pelvic region. We have a smoothish and a rough surface of the pelvis, and a similar arrangement on the sacrum. And they are coloured for convenience. The smooth surface is that ear-shaped or auricular surface, a synovial joint, and the other surface is the rough sacral tuberosity for attachment of ligament. And the fact that the ligament attaches next to the synovial joint actually restricts the amount of movement available at that synovial joint. We have some movement, but not a great deal, between these two opposing bones. This might be a sort of question you get in the exam as well. What movements are available at the subtalar joint? So you have to know what it is to start with. And then, which muscles are of primary importance in generating these movements? Remember, the ankle joint proper is the talocrural joint, and is the articulation primarily between the distal tibia and the talus, but there's also a little bit of support laterally from the fibula, forming that mortise joint in which the talus sits between the two, the medial and lateral epicondyles. Subtalar joint is between the talus and the calcaneus. And these are the bones, in case you're wondering. Can you identify them? Calcaneus, talus. Wonder what this would be. And this. Well, by the time we get here, we're into the metatarsals. This is a lateral perspective, which would make that metatarsal 5, which would make this tarsal bone the cuboid, which would make this tarsal bone the navicular. And it's the navicular that articulates directly with the more distal portion of the talus. And then we can only see two of the cuneiforms. This one would be the lateral cuneiform, the intermediate, and we can't see the medial one because it's over the hill. And these would be examples of a correct answer. Inversion and eversion of the foot, or the forefoot, would be a good descriptor. And we have two primary inverters, tibialis anterior and tibialis posterior. These pass around the medial side of the ankle joint, and more importantly, medial to the subtalar joint. And their shortening will raise the medial border of the foot and invert it. Eversion is primarily by fibularis brevis and longus. These are kind of equivalent muscles, but passing on the lateral aspect of the ankle and subtalar joint. Remember, fibularis longus runs along the plantar surface to insert on the base of metatarsal 1 on the medial side of the foot. And compare it with tibialis anterior, and you can see that the insertion sites are on the same region of the skeleton, but on the plantar surface as opposed to the dorsal surface. Select one muscle of the lower limb that crosses at least two joints. Describe its structure and function and include a description of origins and insertions of the muscle you select. This would be a reasonable sort of question because it allows you a lot of latitude in terms of what you can pick. Some muscles are easier to remember, origins and insertions and others. And you've got a lot to choose from. And I'll reiterate that I'm not going to put any great emphasis on intrinsic muscles of hands and feet beyond things that particularly in the hand, beyond what I mentioned there, but in the foot, most of those intrinsic muscles are of lesser importance. And as such, if any questions do sneak in, they won't be very many of them or of great import. So all these images are going to be available on the web in about 10 minutes when I get back to my office. And with that, I wish you good sailing.